Imagine stepping into this specialized chamber, usually for deep sea divers.
Right.
Only you're not there for a dive. You're there to heal something, maybe a chronic wound, or reverse poison effects, maybe even recover from some kind of severe inflammation.
Mm-hmm.
So you lie down, the doors seal, and then the pressure starts to climb. Way higher than the normal air pressure you feel right now.
Significantly higher.
Yep.
You measure it in atmospheres absolute or ATA. Normal is 1 ATA.
And then instead of breathing normal air, which is only 21% oxygen,
Roughly, yeah.
you start breathing 100% core medical grade oxygen.
And that combination, that intense mix of pure O2 delivered at pressures, significantly higher than normal, usually starting around 1.4 ATA minimum. That's the core idea behind hyperbaric oxygen therapy, HBOT.
And today, that's exactly where we're going.
Cool.
We are diving deep into that pressurized world.
Yeah.
Our mission really is to get way beyond just the classic uses like, treating divers with the bends.
Right. Decompression sickness. Important, but HBT is much broader now.
Exactly. We want to unpack the fundamental physics, how this therapy can actually re-engineer the body's whole oxygen delivery system.
It's pretty amazing when you get down to the mechanics.
We're going to spend some real time on the, frankly, surprising cellular and immunological effects. We'll look at the established treatments, the ones recognized by groups like the UHMS.
The Undersea and Hyperbaric Medical Society, yeah. They set the standards.
And then we'll investigate the cutting-edge stuff emerging from this big global registry conditions like long COVID, inflammatory bowel disease.
Really interesting developments there.
So by the end of this, you are going to understand exactly what happens when you crank up the pressure on the body's oxygen supply. We'll separate the proven science from, the potential frontiers. Okay, let's start right inside that chamber. For anyone listening who hasn't actually seen one, what is the HBOT environment like? It sounds pretty technical.
It is meticulously controlled. I mean, it has to be. You're delivering 100% pure oxygen in a chamber that's pressurized, typically ranging from that 1.4 ATA we mentioned, which is, a bit above normal, all the way up to 3.0 ATA for certain conditions.
And how long would a typical session last?
That varies quite a bit. Usually it's anywhere from maybe 30 minutes to a full 2 hours per session. It really depends entirely on what condition is being treated. The protocols are very specific.
And the chambers themselves, there are different types, right? It's not just one kind of setup.
Correct. There are two main types. The one people probably picture most often is the monoplace chamber.
Like a clear tube.
Exactly. Often a clear acrylic cylinder. It's designed for just one person. The patient lies down inside, and the entire chamber, the whole environment, is pressurized with 100% oxygen.
Seems straightforward, logistically.
It is in some ways, but it can definitely be a challenge for patients who are claustrophobic. Lying in a clear tube isn't for everyone.
Okay, so what's the alternative, the group setting?
That's the multiplace chamber. Think more like a small room or almost like a compartment inside a submarine. It's big enough to treat multiple people at once.
Ah, so you could have staff inside too.
Precisely, which is crucial for treating critically ill patients who need monitoring or specific equipment with them. Now, here's the key difference in operation. The room itself is pressurized with compressed air.
Not pure oxygen.
No, just regular air under pressure. It's cheaper and much safer for the staff working inside. The patients then breathe the 100% oxygen through a specialized system, usually a very tightly fitted mask or sometimes a transparent hood that goes over their head.
I noticed in the source material they made a point about the mask versus the hood delivery methods, specifically regarding eye safety.
Yes, that's actually a really important clinical detail. If you're in a monoplace chamber or using a hood, your entire face, including your eyes, is directly exposed to that 100% oxygen environment. But using a specialized sealed mask in a multiplace chamber means the high concentration oxygen is delivered just to the nose and mouth. This might actually be a safer option for reducing potential ocular complications, especially for patients prone to things like glaucoma.
Why is that?
Well, the concern is that repeated direct exposure of the eye surface to very high oxygen concentrations could potentially pose risks over time. So, for certain individuals, the mask is often the preferred way to go.
Got it. Okay, let's shift gears to the mechanics. The real power of HBOT isn't some fancy drug, right? It's literally applying physics laws to the body. We should probably start with Boyle's law. That seems to cover the emergency stuff.
Absolutely. Boyle's law is, pretty fundamental physics. It states that the volume of a gas is inversely proportional to the ambient pressure. Simple idea. You increase the pressure, the gas volume shrinks.
And how does that apply in a medical emergency?
It's the basis for treating conditions where you have actual gas bubbles causing problems in the body. Think decompression sickness or the bends where nitrogen bubbles form in tissues after diving.
Or like an air embolism?
Exactly. Air gas embolism, or AGE. That's where air bubbles get into the bloodstream and physically block blood flow, often to the brain or heart. That's a true emergency.
So if someone has a severe AGE, say an air bubble, blocking an artery to the brain, how does Boyle's law work instantly?
It's purely mechanical shrinkage. By putting that patient into the chamber and rapidly increasing the pressure, sometimes up to 6 ATA initially, though treatment protocols usually use 2.8 to 3.0 ATA, you are physically compressing that bubble.
Like squeezing it smaller.
Precisely.
Yeah.
Let's say you have a bubble that's 20 milliliters at sea level, 1 ATA.
Yeah.
If you take the pressure up to 4 ATA, Boyle's law tells us that bubble volume instantly shrinks by 75%, down to just 5 milliliters.
Wow, okay.
That physical reduction in size can immediately relieve the blockage in the blood vessel, restoring critical blood flow, especially in the brain where every second counts. That's why immediate HBOT is just standard practice in diving medicine and for AGE.
So Boyle's law is the fast fix for bubbles. But the real healing, the stuff that helps with chronic wounds or inflammation, that relies on a different principle, right?
Henry's law.
Yes, Henry's law. This is where we move from just shrinking things to actually changing the chemistry, the saturation. Henry's law is, you could say, the core mechanism, the real secret sauce of HBOT for most indications.
And what does Henry's law state?
It says that the amount of a gas that can dissolve in a liquid is directly proportional to the partial pressure of that gas above the liquid. More pressure, more gas dissolves.
Okay, let's relate that to oxygen in our blood. Normally, how does oxygen get around? It's mostly carried, isn't it?
It is. A healthy person breathing normal air, something like 97% or more of the oxygen we use is chemically bound to hemoglobin inside our red blood cells. It's like oxygen is riding a train.
And the plasma, the liquid part of the blood. Only a tiny fraction, maybe 3% or less, is physically dissolved in the plasma itself. This system works great when your circulation is fine. But if you have damage, a blockage, swelling, what we call hypoxia or ischemia of the train, the hemoglobin simply can't reach the destination tissues.
So even if I put on an oxygen mask and breathe 100% O2 at normal pressure here at sea level, 1 ATA, I'm still mostly relying on that hemoglobin train system.
Pretty much. Breathing 100% oxygen at 1 ATA does boost the dissolved amount a bit. You get about 1.71 milliliters of O2 per deciliter of blood dissolved in the plasma.
Which sounds like an improvement.
It is, but relative to the total amount of oxygen your blood carries, it's only about a 7.26% net increase. It helps, sure, but if you've got really poor circulation to a wound, that small boost often just isn't enough to make a difference. The train still can't get there.
Okay, now let's put the patient in the chamber. Crank up the pressure. Say we go to a standard therapeutic dose, maybe 3 ATA. How does Henry's law change the game now?
It changes everything because now we're combining two factors,
Yeah.
100% oxygen and triple the normal atmospheric pressure. At 3 ATA, the total pressure is huge, 2,280 millimeters of mercury.
And the effect on dissolved oxygen?
Under those hyperbaric conditions, the amount of oxygen dissolving directly into the plasma skyrockets. We're talking at least 4.8 milliliters of oxygen per deciliter of blood.
Okay, wait. 1.71 LLDL breathing 100% O2 at normal pressure versus 4.8 LLDL at 3 ATA. That's nearly 3 times as much dissolved oxygen.
Exactly. And remember that net increase. Instead of just 7%, this represents a net increase of 22.5% in the total oxygen content of the blood. But here's the absolutely critical part.
Go on.
Tissues at rest, just ticking over, typically need about 60 milliliters of oxygen per liter of blood. That's 6 millivalor per DL. With HBOT at 3 ATA, that 4.8 LDL of oxygen dissolved just in the plasma, that's almost enough to meet the entire tissue demand at rest.
Without needing the hemoglobin at all.
Essentially, yes. The hemoglobin becomes almost like a bonus reserve. The plasma itself, which can seep into the tiniest capillaries, flow around blockages, get into the interstitial fluid, that becomes the primary supercharged oxygen delivery system.
Wow. So it's like you're bypassing the blocked roads entirely.
That's a perfect analogy. We make oxygen delivery independent of red blood cell function and hemoglobin binding. Because the oxygen is just dissolved, the high pressure creates this overwhelming concentration gradient. Oxygen is literally forced into the tissues.
And you mentioned it diffuses further.
Significantly further. This massive increase in dissolved plasma oxygen enhances diffusion into severely hypoxic or poorly perfused tissues. We estimate it pushes oxygen about 4 times the normal perfusion distance. So, instead of relying on that potentially blocked highway, the red cells in larger vessels, we've effectively turned the entire landscape, the plasma itself, into a flowing river of oxygen that saturates everything it touches.
Okay, so we've got the physics down. Increased pressure dissolves way more oxygen directly into the plasma. Now let's connect that to the biology. What exactly is happening at the cellular level when tissues are starved of oxygen hypoxia that HBOT is trying to fix?
Right. So tissue hypoxia, that lack of oxygen, it basically sends the cell into crisis mode. It's a mater stress. The stress activates these internal sensors, proteins called hypoxia-inducible factors, or HIFs.
And HIFs are supposed to help the cell adapt, right?
Initially, yes. They try to help the cell switch to less efficient emergency energy production methods, like glycolysis. It's a survival mechanism.
But in chronic situations like a non-healing wound or severe injury, does this HIF activation become a problem?
It absolutely can. The
Yeah.
activation of HIF doesn't just trigger energy switching. It also kicks off this dangerous feedback loop involving inflammation. HIF actually promotes the activity of a really potent inflammatory pathway called NFD.
NF-kappa B, I've heard of that.
Yeah.
Very pro-inflammatory.
Extremely. NFDB then triggers the release of a flood of pro-inflammatory cytokines. These cause blood vessels to leak, tissue swells up edema, and that further compromises blood flow. So the hypoxia causes inflammation, and the inflammation makes the hypoxia worse.
A vicious cycle.
Precisely, a self-perpetuating cycle of cellular damage and tissue breakdown.
So HBOT, by delivering all that extra oxygen, isn't just feeding the starved cells, it's trying to break that cycle. How does creating hyperoxia, the opposite of hypoxia, in that HIF pathway?
By flooding the tissue with oxygen, you're essentially stabilizing the enzymes that normally keep HIF in check. These are called prola hydroxylase domain enzymes, PHD, and factor-inhibiting HIF, or FIH.
Okay.
These enzymes need oxygen to work. When oxygen is abundant, like during HBOT, PHD, and FIH function properly, they basically tag the HIF protein for destruction.
So you turn off the cell's panic alarm HIF because the oxygen emergency is over.
That's a great way to put it. With HIF inactivated, the inflammatory cascade driven by NFPB quiets down. The cells can switch back to their normal, much more efficient way of making energy oxidative metabolism, which generates plenty of ATP.
And having more energy helps them survive the injury.
Significantly, they're much better equipped to handle the initial damage and the ongoing stress. It helps reverse that downward spiral towards tissue death.
Okay, that makes sense for stopping the damage. Now let's talk about the repair side. The sources mention these dual effects of hyperoxia. One of them, though, seems counterintuitive. Vasoconstriction.
Ah, yes, the paradox of HBOT.
Right. You said high oxygen makes blood vessels constrict except in the lungs. If we're trying to heal tissue that's starved because of poor blood flow, isn't shrinking the blood vessels the last thing you want to do?
It's an excellent question, and it really highlights why the dissolved oxygen piece is so critical. Yes, hyperoxia does cause vasoconstriction. Blood flow volume can decrease by maybe 20%. And you're right, if our only way to get oxygen there was via hemoglobin in those vessels, that constriction would be terrible.
But because of Henry's law.
Exactly. Because we've supersaturated the plasma with dissolved oxygen, we can afford that reduction in flow volume. In fact, the vasoconstriction is actually beneficial in many cases.
How so?
Because it significantly reduces edema, that tissue swelling. Think about crush injuries or burns. A lot of the secondary damage comes from massive swelling, compressing tissues, and blocking microcirculation. HBOT's vasoconstriction helps minimize that swelling.
So less swelling and the plasma oxygen still gets through.
Precisely. Even with slightly less blood volume flowing per minute, the blood that is flowing is so incredibly rich in dissolved oxygen that the net delivery of oxygen to the tissue is still far greater than normal. Plus, you get the benefit of reduced tissue pressure from the decreased edema. It's a clever physiological trade-off.
Okay, I get it now. Vasoconstriction helps control swelling, and the dissolved O2 compensates for the reduced flow. What about the longer-term secondary effects, the actual rebuilding?
This is where we see true tissue regeneration kick in. Many of the enzymes and cellular processes involved in healing require oxygen as a critical component. HBOT provides that in abundance. Specifically, it's known to stimulate angiogenesis, that's the growth of new blood vessels into the damaged area.
Which is vital for restoring permanent circulation.
Absolutely.
Huh.
And it also promotes the formation of collagen, which is the protein scaffold, the structural matrix needed to rebuild tissue. You need both new pipes and new building blocks.
And then there's the really exciting part, linking HBOT to more systemic repair, stem cells.
Yes. This has become a major focus of research. A significant part of HBOT's benefit, especially in chronic wounds that just refuse to heal, seems to come from its ability to mobilize stem cells, specifically progenitor stem cells.
Mobilize them from where?
From the bone marrow. HBOT appears to trigger their release into the bloodstream and also enhances their ability to home in on the signals coming from the injured tissue. So more repair cells get delivered exactly where they're needed.
That stem cell finding leads us straight into something fascinating from the sources, this placebo challenge. For years, researchers used what they thought was a sham treatment in HBOT trials.
Right. They often used hyperbaric air at a lower pressure, typically around 1.2 or 1.3 ATA. Say 1.27 ATA was a common one.
And the thinking was, that's not enough pressure or enough oxygen to actually do anything biologically.
Exactly. The prevailing wisdom was you needed to hit that higher pressure threshold, like 1.4 ATA or ideally 2.0 ATA and above, and use 100% oxygen to really drive up the dissolved oxygen via Henry's law. They figured just a little bit of extra pressure with normal air, which is only 21% oxygen, wouldn't be enough to cause a physiological effect. It was considered a true placebo.
But then someone actually tested that placebo.
Yes, and the results were, well, a bit stunning. They took healthy people and exposed them to 10 sessions, 90 minutes each, of just 1.27 ATA hyperbaric air. No extra oxygen, just slightly pressurized room air.
And what happened?
They saw a significant mobilization of progenitor stem cells, specifically CD34 plus cells, which are involved in blood cell formation, and also CD31 plus CD105 cells, which are thought to be pro-angiogenic, meaning they help build new blood vessels. The levels in the blood jumped nearly 2 to 3 times higher than baseline.
Just from slightly pressurized air.
Just from the pressure. And the effect wasn't fleeting. It lasted for at least 72 hours after the last session.
So that placebo was actually an active treatment all along.
It certainly seems so. It strongly suggests that stem cell mobilization might be triggered by pressure itself, or perhaps is much more sensitive to smaller increases in oxygen partial pressure than we thought. It implies there might be a dose-response relationship.
This basically throws a wrench into interpreting years of clinical trial data, doesn't it?
It really does. Any trial that used that kind of hyperbaric air as a control needs to be reevaluated because the control group was likely receiving an active physiologic intervention, not a true placebo.
It forces a rethink. Maybe the systemic regeneration aspect, the stem cell part, kicks in at lower thresholds than the direct tissue oxygenation part.
That's a key hypothesis now. It tells us the systemic effects of changing atmosphere and pressure might be more profound and sensitive than we ever realized.
Okay, one last crucial point in this section. Given all this talk about regeneration and cell stimulation, is there a risk that HBOT could accelerate all growth? Like, could it make tumors grow faster or speed up healing in perfectly healthy tissue where you don't need it?
That's a really important concern, and thankfully the evidence is quite clear on this. HBOT does not seem to accelerate the healing of normal, healthy wounds. Its benefits are very targeted towards tissue that is ischemic, damaged, or stuck in a non-healing state. It helps fix what's broken.
And cancer.
Similarly, HBOT appears to have little to no effect on tumor progression. The reason is likely that the tumor microenvironment is very different from a chronic wound. While tumors are often hypoxic in the center, their blood supply is usually chaotic and poorly formed. HBOT helps chronic wounds by fixing vascular defects and promoting organized angiogenesis and collagen deposition. It doesn't seem to provide that same kind of benefit or accelerate the disorganized growth within a tumor. It's about fixing deficits, not just stimulating all cell division.
All right, we've got the physics, we've got the cellular biology. Now let's look at where HBOT is already a standard accepted medical treatment. The UHMS, the Undersea and Hyperbaric Medical Society, has a list of approved indications. How many are there currently?
Right now, there are 14 conditions for which HBOT is recognized by UHMS as having sufficient evidence for efficacy.
We mentioned decompression sickness and air embolism. What are some of the other key ones that people might not know about?
Well, a big category involves tissue damage due to compromised blood supply or severe infections. For instance, it's approved for compromised skin grafts and flaps. That means if tissue has been moved or transplanted, say after surgery or injury, and it's starting to fail because it's not getting enough blood, HBOT can help salvage it.
And specific infections.
Yes, critically important for certain nasty ones. Gas gangrene caused by Clostridium bacteria is a classic indication, and also necrotizing soft tissue infections, sometimes called flesh-eating bacteria.
How does HBOT fight something like gas gangrene? Isn't that caused by bacteria that hate oxygen?
Exactly. Clostridium perfringens is an anaerobe. It thrives in low oxygen conditions and produces toxins that rapidly destroy muscle. HBOT tackles this in two ways. First, flooding the tissue with high-pressure oxygen creates an environment that's directly toxic to the anaerobic bacteria, inhibiting their growth and toxin production.
Buys time, basically.
It buys critical time. Second, the hyperoxia enhances the ability of our own white blood cells to kill bacteria. So it helps antibiotics work better and allows surgeons to more effectively remove the dead tissue. It dramatically improves outcomes in what can be a rapidly fatal infection.
Another surprising one, perhaps, is for damage caused by radiation therapy, but often years later.
Yes, the late effects of radiation therapy. This is a major use. Radiation kills cancer, but it can also damage healthy tissue by destroying the tiny blood vessels, the microvasculature. This creates chronic hypoxia and fibrosis long after the radiation treatment ends.
Leading to problems like
You might see radiation proctitis, which is damage and inflammation in the rectum, or cystitis in the bladder. These can cause chronic pain, bleeding, and dysfunction. HBOT works here by stimulating angiogenesis, growing new blood vessels back into that damaged hypoxic tissue. It essentially helps rebuild the circulation that the radiation destroyed.
it's reversing the long-term side effect.
Precisely, helping the tissue heal itself from the inside out.
What about bone infections? I understand it's used for really stubborn cases.
Right, refractory osteomyelitis. That's a chronic bone infection that just hasn't cleared up with standard treatments like antibiotics and surgery. Often, the problem is that the infection site in the bone is so damaged, maybe with dead bone fragments or scarred, that blood flow is terrible.
So antibiotics can't even get there.
Exactly, they can't reach therapeutic concentrations. Plus, the low oxygen environment hinders the body's own cleanup crew cells called osteoclasts that remove dead bone and impairs immune cell function.
And HBOT helps out.
Again, multiple ways. The high oxygen levels can be directly harmful to some bacteria involved. More importantly, it enhances white blood cell killing power, and it stimulates those osteoclasts and other cells needed for bone remodeling and healing. It basically makes that dead zone in the bone accessible to healing again.
Okay, let's pivot to the really acute life or death uses. Carbon monoxide poisoning. You hear about HBOT for this all the time. Why is CO so uniquely dangerous?
CO poisoning is a huge medical emergency. The main issue, as most people know, is that CO binds to hemoglobin in our red blood cells much, much more tightly than oxygen does, about 240 times the affinity.
So it kicks oxygen off the hemoglobin molecule.
Yes. It effectively suffocates you from the inside by preventing oxygen transport, even if you're breathing air with plenty of oxygen. The patient might even look pink, but their tissues are starving.
But you mentioned earlier, it's not just about the hemoglobin binding, there's a deeper toxicity.
That's the critical part for long-term outcomes. While most CO binds hemoglobin, about 10–15% gets inside the cells and binds directly to other molecules. The most crucial target is an enzyme in the mitochondria called cytochrome C oxidase.
Mitochondria, the cell's power plants.
Exactly. Cytochrome C oxidase is the final step in the process where cells use oxygen to generate energy, ATP. CO binding poisons this enzyme, effectively shutting down the cell's ability to use oxygen even if oxygen is present.
So even after the CO is cleared from the blood, the cells can't make energy properly.
Right. And this mitochondrial poisoning is especially damaging to the organs that need the most energy, the brain and the heart. This is why patients can seem to recover initially but then develop serious delayed neurological problems days or weeks later. Up to 40% of severe poisoning cases see this.
So treatment isn't just about getting CO off hemoglobin, it's about preventing that delayed brain damage. Time is critical. What's the standard first step?
Immediate 100% oxygen, usually given through a non-rebreather mask. But here's the catch. Breathing 100% oxygen at normal sea level pressure, 1 ATA, the half-life of CO bound to hemoglobin, the time it takes to remove half of it, is still really long. About 250 minutes.
Over 4 hours.
Yeah, that's potentially 4 hours where CO is still damaging mitochondria. It's often too slow to prevent those delayed effects.
And how much faster is HBOT?
Dramatically faster. Putting the patient in a chamber with 100% oxygen at 3 ATA reduces the CO half-life to just 20 to 30 minutes. You're clearing the poison out of the blood incredibly quickly. And maybe just as importantly, you're flooding the tissues with that huge amount of dissolved plasma oxygen, which helps bypass the poison hemoglobin and supports the mitochondria while the CO clears.
So when do doctors decide to move from the oxygen mask to the hyperbaric chamber? What are the triggers?
The threshold is generally quite low because preventing those delayed neurological problems is paramount. HBOT is definitely indicated if the patient had any loss of consciousness, no matter how brief, or if they show any new neurological signs, confusion, dizziness, coordination problems, seizures.
What about other signs?
Evidence of significant organ damage is another trigger, so ECG changes suggesting heart strain or severe metabolic acidosis, a blood pH below 7.1 indicating widespread tissue distress. Basically, any sign that the poisoning is severe.
And you specifically highlighted pregnant patients earlier. Why the extra urgency there?
Yes, pregnancy is a special case. Fetal hemoglobin actually binds CO even more tightly than adult hemoglobin. So the fetus holds onto the CO for much longer and is extremely vulnerable to brain damage or even death.
So even if the mother seems okay.
Even if the mother's symptoms seem relatively mild, if her carboxyhemoglobin level is significantly elevated, often the threshold used is above 20%. HBOT is strongly considered beneficial, primarily to protect the fetus. It's one of the few situations where the benefit clearly outweighs any potential risks of HBOT during pregnancy.
Okay, we've covered the rock-solid established uses, but like you said, the field is moving. Let's talk about the frontiers. You mentioned this international registry for HBOT. What exactly is that, and why is its data so interesting?
Yeah, this registry is a fantastic initiative. It's essentially a large ongoing project collecting standardized anonymous outcome data from, I think, 32 different hyperbaric centers around the world, US, UK, Australia, others.
Yeah, they're tracking outcomes for conditions not yet on that official UHMS-approved list.
Exactly. They call them emerging indications. These are conditions where doctors are trying HBOT based on theoretical benefits or smaller studies, and the registry pools the real-world results. They've got data on thousands of patients covering dozens of these potential new uses.
And what's topping the list? What are clinicians using HBOT for most often in this emerging category?
By far the most frequent is post-COVID-19 condition, or PCC, long COVID. It accounts for almost 40%, 39.4% to be exact, of all the emerging indication cases reported in the registry.
Nearly 40%. Why the interest in HBOT for long COVID? What's the thinking?
Well, the leading hypothesis for many long COVID symptoms, especially the fatigue and the brain fog, involves persistent inflammation, maybe problems with microcirculation, and possibly ongoing issues within the nervous system, neuroinflammation.
And HBOT targets inflammation and circulation.
Right. Given HBOT's known anti-inflammatory effects, its ability to improve oxygen delivery past microvascular issues, and maybe even modulate immune responses, it seems like a really logical fit to try and address those underlying problems in PCC.
Okay, but we need to be careful with registry data, right?
Yeah.
It's not the same as a gold standard randomized controlled trial, RCT.
Absolutely. That's a critical caveat for you listening. Registry data gives us valuable real-world snapshots, but it's not controlled. There can be selection bias. Maybe doctors are only treating patients they think will do well. We don't have a proper placebo group.
So we take the results with a grain of salt.
We interpret them cautiously. But when you see really strong, consistent, positive signals across many patients and centers, like with PCC, it provides powerful justification to then design and run those definitive RCTs. It points researchers in the right direction.
So what did the registry data show for these long COVID patients undergoing HBOT?
The improvements reported were pretty substantial, actually. They used standard questionnaires. For neurocognitive symptoms using the Neurobehavioral Symptom Inventory, NSI, average scores dropped significantly from about 30.6 before treatment down to 14.4 after. That's a big improvement in things like concentration, memory, and processing speed.
And quality of life?
That improved dramatically, too. Using a scale called the EQ5D VAS, where patients rate their overall health, the average score nearly doubled. It went from a pretty low 33.6 before HBOT up to 64.1 afterwards.
And you mentioned this aligns with some emerging RCT data too.
Yes. These registry findings seem to be backed up by some recently published randomized trials, which are also showing objective improvements in cognitive function and symptoms for long COVID patients treated with HBOT compared to control groups. So the evidence is building.
Interesting. Okay. Moving beyond viral after effects, the registry also showed a lot of use for chronic internal inflammation, specifically inflammatory bowel disease, IBD.
That's right. IBD, which includes both ulcerative colitis, UC, and Crohn's disease, CD, was the second biggest category. Combined, they accounted for about 23% of the emerging cases.
That's significant. It really shows clinicians are thinking about HBOT for systemic inflammation inside the body, not just, skin wounds or bones.
Definitely. It marks a shift towards using HBOT as potentially an anti-inflammatory and tissue healing tool for internal organs.
What did the data show specifically for Crohn's disease patients? Crohn's can be really tough, with fistulas and deep inflammation.
It can be devastating. The registry data showed Crohn's patients reporting significantly better quality of life scores after HBOT, a DQ5D, went from an average of 53.8 up to 68.8. And clinically, perhaps most impressively, 5 patients, which was 13% of the group with that data, reported complete closure of a fistula.
Wow, closing a fistula with that surgery is a big deal.
It absolutely is. Fistulas are notoriously difficult to heal. Also, patients who had perianal Crohn's disease, which involves fistulas near the anus, reported a significant decrease in discharge, suggesting healing was occurring.
And the theory there is similar, reducing inflammation, improving oxygen supply to the gut lining.
Yes. The idea is that HBOT helps heal the microscopic ulcerations, improves blood flow to the inflamed bowel wall, and breaks that local cycle of hypoxia and inflammation that drives the disease.
What about the other main type of IBD, ulcerative colitis?
For UC, which mainly affects the colon's lining, patients who provided complete data also reported better quality of life. They also had lower scores on specific bowel symptom questionnaires, meaning less bowel frequency, less blood, less pain, less urgency. Again, suggesting HBOT is helping to calm the inflammation and promote mucosal healing.
Let's quickly touch on a few other emerging areas highlighted in the registry data. There was calciphylaxis. That sounds nasty.
It is. Calciphylaxis is a really severe, thankfully rare, condition mostly seen in patients with kidney failure. They get calcium deposits blocking tiny blood vessels in the skin and fat, leading to incredibly painful, non-healing necrotic ulcers. Mortality is very high.
And HBOT showed promise.
Some promise. Of the 20 calciphylaxis patients in the registry, about 45% reported improvement with HBOT. It's encouraging, but the results are still considered mixed, mainly because the disease itself is just so aggressive and difficult to treat. HBOT is likely one tool among others.
Okay, how about frostbite? Treating tissue damaged by cold.
The registry outcomes for frostbite seem to support findings from other studies. When HBOT is used alongside standard treatments like drugs that dilate blood vessels, such as Alaprost, it appears to lead to a significantly higher rate of salvaging frostbitten fingers and toes, reducing the need for amputation.
Makes sense, forcing oxygen into those severely constricted, cold-damaged tissues.
Exactly. Maximize oxygen delivery to keep as much tissue alive as possible.
Now, this next one is fascinating because it gets into the mechanism of how HBOT might work in autoimmune diseases. Studies on rheumatoid arthritis, but in animal models.
Yes, this moves us from registry observations into controlled lab research, trying to understand how HBOT affects the immune system. They used mouse models of rheumatoid arthritis, RA.
And what did they find when they treated these arthritic mice with HBOT?
They found that HBOT significantly reduced the clinical signs of arthritis, less paw swelling, better mobility scores. But more importantly, they looked at why.
What changed immunologically?
HBOT treatment led to decreased levels of several key pro-inflammatory markers associated with RA, things like HIF1, hypoxia factor again, IL-17A, a major inflammatory cytokine in RA, and rheumatoid factor itself. But here's the kicker. At the same time, HBOT increased the number of regulatory T cells, or TREG cells.
TREGs are the good guys of the immune system, right? They
Yes.
suppress inflammation.
Exactly. They're crucial for maintaining immune balance and preventing autoimmunity. So the findings suggest HBOT might be actively shifting the immune response. It seems to push the balance away from the aggressive inflammatory Th17 cells towards these calming anti-inflammatory TREG cells.
So HBOT might not just be delivering oxygen, it might be actively re-educating the immune system in certain inflammatory conditions.
That's the really exciting implication. It suggests a potential mechanism for how HBOT could benefit not just RA, but maybe also IBD, perhaps even aspects of long COVID, by fundamentally modulating the underlying immune dysfunction. It's a potential paradigm shift.
Wow. Okay, and just briefly wrapping up the emerging uses ophthalmology eye conditions.
Yes, there's growing interest there too. Several serious eye conditions involve problems with blood supply and oxygen delivery to the retina or optic nerve. Things like central retinal artery occlusion, like a stroke in the eye, retinal vein occlusion, or certain types of optic neuropathy.
And the logic is straightforward.
Pretty much. Since HBOT's main trick is delivering dissolved oxygen past blockages and into hypoxic tissue, conditions where the eye's delicate structures are starved of oxygen seem like a natural fit for exploring HBOT as a potential therapy. Research is ongoing.
Okay, we've talked a lot about the benefits and the potential, but any treatment this powerful must have risks, right? We need to be clear about the safety side. Modern HBOT is considered safe, but what are the common issues patients need to know about?
You're right, safety protocols are paramount, and HBOT, when done correctly, is actually one of the safer medical therapies. But yes, there are side effects. By far the most common issue patients run into is middle ear barotrauma, or M.
Ear pain from the pressure.
Exactly, it's purely mechanical. As the pressure increases in the chamber during compression, if your eustachian tubes, the little tubes connecting your middle ear to the back of your throat, don't open properly to equalize that pressure, it builds up against your eardrum.
Like on an airplane, but more intense.
Much more intense, potentially. It can cause significant pain, sometimes fluid buildup behind the eardrum, or in rare cases, even rupture the eardrum if it's not managed.
How do patients manage it?
They have to actively clear their airs throughout the compression phase. Techniques like the Valsalva maneuver, pinching your nose and gently blowing or yawning, swallowing, wiggling the jaw. The technicians guide them through it. While usually mild and temporary, MEB is the #1 reason a treatment session might need to be slowed down, paused, or occasionally stopped.
What about the chamber itself, being enclosed?
That's the other common practical issue, claustrophobia, especially in those single-person monoplace chambers, which can feel quite confining.
What happens if someone is too anxious?
If the anxiety is severe, they might be referred to a facility with a multi-place chamber, which feels more like a room and is less claustrophobic. Sometimes mild anxiolytic medication like Valium might be prescribed beforehand, but only under careful medical supervision to help them tolerate the treatment.
Okay, those are the common discomforts. What about more serious risks related to the pressure itself? We talked about Boyle's law, shrinking bubbles. Does it work in reverse during decompression?
It absolutely does. And that's where the main pressure-related risk comes in. Pulmonary barotrauma, or PBT, lung damage from pressure.
How does that happen?
If a patient has a condition that causes air trapping, meaning air gets into a part of the lung but can't easily get out, maybe due to scarring, mucus plugs, or bronchospasm, then during the decompression phase, as the chamber pressure drops, that trapped air expands according to Boyle's law.
And if it can't escape?
The expanding air can overstretch and rupture the lung tissue, causing a pneumothorax, a collapsed lung. Air leaks into the chest cavity.
Which patients are most at risk for this air trapping?
People with certain lung conditions need careful screening. Severe uncontrolled asthma, COPD with active wheezing, or specific conditions like bullous emphysema, where they have large, weak air sacs in the lungs. This is why a thorough medical history and sometimes chest x-rays or CT scans are mandatory before starting HBOT. PBT is very rare in people with healthy lungs, but it's a major concern if underlying lung disease is present.
All right, that covers pressure risks. What about risks from the oxygen itself? Can you get too much of a good thing? Oxygen toxicity.
Yes, oxygen toxicity is a real phenomenon. It depends on both the dose, the pressure of oxygen breathed, and the duration of exposure. The most concerning type is central nervous system, CNS, toxicity.
What does that look like?
It typically manifests as a seizure, similar to an epileptic seizure. It sounds scary, and it is when it happens, but it's actually quite rare with modern treatment protocols.
And what happens if someone does have a seizure?
The crucial thing is that the seizure is triggered by the high oxygen pressure. As soon as the patient is taken off the 100% oxygen, usually by removing their mask or hood, the seizure almost always stops immediately. There's typically no lasting neurological damage from the seizure itself.
Do they have to stop treatment entirely?
Not usually. The treatment protocol is then carefully adjusted, maybe lower pressure, shorter duration, or longer air breaks to reduce the risk, and most patients can continue treatment safely. However, certain factors do increase the risk of CNS toxicity, like having a high fever, uncontrolled high blood pressure, or a known history of epilepsy. Extra caution is needed in those cases.
Okay. We touched on eye issues earlier with the mask versus hood. What are the established side effects of repeated HBOT on the eyes?
The most well-documented ocular side effect is a progressive myopia or nearsightedness.
Your vision gets blurrier for distance.
Exactly. It seems that high oxygen levels cause temporary changes in the refractive power of the eye's lens. The sources mention it can shift the prescription by about a quarter of a diopter per week, especially at pressures over 2.0 ATA.
Is this change permanent?
Thankfully, no. It's generally considered reversible. The vision usually returns to baseline within about 6 to 8 weeks after the entire course of HBOT is finished. That's why patients are always advised not to get new glasses made until well after their treatments end.
Are there any permanent eye risks?
There is a potential risk of cataract formation or acceleration, but this seems to be rare and typically associated only with very long courses of treatment, usually more than 100 or 150 sessions. And as we discussed, there's that theoretical concern in glaucoma patients about high oxygen potentially affecting the eye's drainage system, which reinforces the idea that mask delivery might be preferable sometimes.
Got it. What about things patients do that could interfere with treatment or make it riskier? Lifestyle factors, drugs.
Yes, this is important. Because HBOT relies on good blood flow to deliver that extra oxygen, anything that causes vasoconstriction narrowing of blood vessels is counterproductive. So nicotine use from smoking or vaping is strongly discouraged.
Makes the treatment less effective.
Significantly less effective. Same goes for caffeine. And obviously, any illicit drugs that cause vasoconstriction, like cocaine or amphetamines, are absolute contraindications. Patients are usually advised to avoid caffeine and nicotine for several hours before each session.
Any other medical conditions or medications to watch out for?
Insulin-dependent diabetes requires careful management. HBOT can actually increase the body's sensitivity to insulin, potentially causing blood sugar to drop too low during or after treatment, hypoglycemia. So close glucose monitoring is essential.
And lung disease.
As we mentioned, COPD is a relative contraindication due to the risk of air trapping, PBT, and also potential issues with CO2 retention and ventilation perfusion mismatch. It requires careful assessment.
And pregnancy?
Pregnancy remains a relative contraindication. It's generally avoided unless there's a truly life-threatening condition for the mother or fetus, where the benefits clearly outweigh any potential risks, with CO poisoning being the prime example.
Before we wrap up the risks, it feels important to briefly acknowledge the history here. Modern HBOT sounds very controlled, but it wasn't always that way, right? Mentioning Dr. Cunningham.
Ah, yes. Dr. Orville J. Cunningham. His story from the 1920s and 30s is a really stark reminder of why rigorous science and safety protocols are so vital. He was a huge proponent of hyperbaric therapy, an entrepreneur, really. He built these enormous hyperbaric chambers. The most famous was a 5-story high steel sphere in Cleveland.
5 stories.
Right.
What did he claim it treated?
Pretty much everything under the sun: diabetes, cancer, arthritis. He operated them at high pressures, but his methods lacked scientific validation and he didn't publish proper data.
And there was an accident.
Tragically, yes. One of his massive chambers suffered a catastrophic failure, a sudden, uncontrolled decompression. Reports say everyone inside at the time died. This disaster, combined with his unsubstantiated claims and refusal to adhere to scientific methods, led to him being censured by the American Medical Association in 1928. His giant chamber was eventually dismantled.
So the strict protocols today, the careful screening, the controlled pressure changes, the treatment limits, the staff training, it's all built on learning from those early, unregulated, and sometimes dangerous days.
Absolutely. The Cunningham story is a cautionary tale. Modern HBOT facilities operate under incredibly strict safety guidelines developed over decades by organizations like the UHMS to ensure that while we harness the power of pressure and oxygen, we do it with minimal risk to the patient. Hashtag outro.
Okay, that was a lot to cover. Let's try and bring it all together. This deep dive into hyperbaric oxygen therapy. It really boils down to physics, doesn't it? It's not some magic bullet drug.
Not at all. It's leveraging a fundamental law of physics, Henry's law. By drastically increasing the pressure, we force huge amounts of oxygen to dissolve directly into the blood plasma. Remember that number 4.8 mLDL at 3 ATA?
And that dissolved oxygen is the key. It allows oxygen to reach tissues that are cut off from normal blood flow, diffusing maybe 4 times further than usual. It bypasses the blockages.
Right. It's a delivery system upgrade when the normal system fails.
And we saw how this core mechanism leads to really well-established uses. Fighting those terrible infections like gas gangrene, healing chronic diabetic foot ulcers, reversing late radiation damage.
And crucially, acting as a frontline, life-saving treatment for carbon monoxide poisoning, clearing the CO rapidly and protecting the brain and heart from that mitochondrial damage.
But the story doesn't stop there. The exciting part is how HBOT seems to be moving beyond just fixing local tissue problems. That registry data points towards systemic effects.
Definitely. We're seeing it applied more and more to complex inflammatory conditions like long COVID and inflammatory bowel disease. The thinking there is that HBOT's benefits come not just from oxygen delivery, but from its powerful anti-inflammatory actions, its ability to promote healing microvasculature, and perhaps most intriguingly, its potential to modulate the immune system and mobilize stem cells for repair.
So for you listening, hopefully you now have this really solid mechanism-based understanding. You see how pressurizing oxygen isn't just for divers anymore. It's a tool that can influence healing right down to the cellular and immunological level.
And that brings us back to that really provocative finding we discussed right near the end there. The fact that even a tiny bit of extra pressure using just normal air, that supposed placebo treatment,
Yeah.
was enough to actively mobilize stem cells in healthy humans. It wasn't inert at all.
Which suggests
It suggests that maybe atmospheric pressure itself, even separate from high concentrations of oxygen, might be a more powerful biological signal than we ever thought. We might just be scratching the surface of how pressure can be harnessed as a regenerative tool.
So here's the final thought to leave you with. If just slightly changing the air pressure around us can trigger something as profound as stem cell mobilization, what other subtle, maybe even everyday changes in our physical environment, things like gravity variations, different light spectrums, maybe even dietary components, we haven't fully understood what untapped physiological power might they hold? Something to think about. We'll see you next time for the next deep dive.